So today I want to help you understand OCD. So including a comprehensive overview of obsessive compulsive disorder, like key symptoms, criteria, impact on individuals. We'll focus a chunk of this on differentiating OCD and subtypes from psychosis. And then if we have some time, we'll build a model of OCD. We'll talk about the underlying mechanisms and cognitive processes involved in OCD, and we'll differentiate it a little bit from the description that's in the DSM, which is really not all that helpful. So what is OCD? So OCD in the DSM involves obsessions, which are unwanted or intrusive thoughts, images, or urges that cause significant distress and anxiety. The DSM describes compulsions, where we engage in repetitive behaviors and mental acts in an attempt to reduce anxiety caused by obsessions. And then these are time-consuming or impairing. So obsessions and compulsions, they account for about an hour a day or more, or they significantly interfere with daily life and functioning. One thing to note here about this is it does say greater than 1 hour in the DSM, but there is an or. So like, for example, one of my patients would use bleach to wash one of her newborn babies. It wasn't taking an hour, but it was obviously significantly impairing and highly distressing and disturbing. So in this case, this criterion would still be met. Obsessions, I said, are unwanted or intrusive thoughts. People with OCD often recognize these as irrational, but they feel unable to control them. It crosses across several domains like contamination, symmetry, or taboo domains like religious domains, sexual, or harm-related. We'll talk a little bit about that later. Compulsions are repetitive physical acts or mental rituals performed to alleviate anxiety or prevent a dreaded event, although they're not typically realistically connected to the feared outcomes. So one example of this might be having to lock the doors 4 times every time we leave the house, or check something 4 times every single time to prevent something terrible happening, like preventing a hurricane from spinning up in Florida and wiping out grandma on the East Coast. Impulses feel like they're driven. So individuals with OCD feel a strong, irresistible urge to engage in compulsions, even if they recognize the behaviors as excessive or irrational. So we talked about repetitive behaviors, and we talked about how they're not often realistically connected to feared outcomes. But when they are, they're excessive or irrational. So consider a surgeon I would work with who would thankfully scrub up for surgery, but this is not what he needed to do when he was preparing chicken at home. And yet this is exactly what was happening because of his fear of contamination. So in this case, he was worried about contamination. So the behaviors did seem like they were connected to the thought of contamination in a realistic way, but the behaviors were clearly excessive. And people who engage in compulsions tend to find that the relief is ineffective. So while the compulsions may provide temporary relief, they don't actually prevent the feared consequence, and they can significantly disrupt daily life and functioning. The DSM has impairment and exclusion criteria, as do all disorders, so it causes significant distress and impairment, which we've talked about. We have to rule out substance use as well as symptoms attributable to medications. And then we have to distinguish this from other disorders, such as preoccupation with appearance, like body dysmorphic disorder, restricted eating and anorexia, illness anxiety disorder, and somatic symptom disorders, or tough differential diagnoses. And as I'm sure you know, the purpose of this presentation would be disorders on the schizophrenia spectrum. Some of the real-life impairment resulting from OCD: about 12.5% of people are hospitalized at least once in their lifetime for moderate to severe OCD. 5.5% have been hospitalized in one survey over the past year. Suicidal ideations higher than in the general population, about 28%, and about 10% is the median rate for individuals with OCD who have an attempted suicide. It's associated with significant impairment at home and social relationships, and academic and professional responsibilities, leads to lower quality of life, especially when there's comorbid depression. But we do have optional specifiers for good, fair insight, poor insight, absent insight, and delusional insight, which we'll talk a lot more about. The lifetime prevalence of OCD: if you're ever writing a grant or a paper or talking to patients, 2 to 4% is a pretty good number to cite there. Some of these are higher rates, like closer to 4% in our youth samples. It's underdiagnosed and undertreated. Many patients often hide their symptoms, which tend to be more private than those and other mental health conditions like major depression or bipolar disorder. So an example of this would be someone who has unwanted and intrusive thoughts about harming others. They might do a very good job of hiding this. And so for this reason, it could be years, even decades before someone actually receives treatment. The onset patterns of OCD, so it does tend to have this bimodal age of onset where we have an early onset between about 6 to 18 years with a male bias, often comorbid with tics and ADHD. Then there's this later onset here with this gray line, which has this female bias, 1/3 of cases occurring before age 15 and a fifth before age 10. Onset after 40 is uncommon. If any of you know Chris Pittenger at CMHC, he'll often jokingly, though I'm not sure he's joking that much, recommend either neuropsych evals or fMRIs or brain scans for people up here in the tails of the distribution. It is evenly distributed across socioeconomic classes worldwide. So we did touch on comorbidities a little bit before. So here are the highest comorbidities, though nothing in the DSM is really off limits. Any anxiety disorder, very high up there. Same thing with mood disorders, impulse control disorders, and substance use disorders. Interestingly, there is some data out there to suggest that smoking is less common with OCD. So I promised we'd come back to the subtypes of OCD, so here they are. So we can, for example, in this study that looked at the Yale-Brown Obsessive Compulsive Scale, which has a checklist of all of the different symptoms that someone might experience when they have OCD, it kind of broke it down into hoarding, body-focused superstition, transformation, separation and loss, harming and checking, forbidden thoughts. So this kind of breaks it down pretty neatly, and we'll come back to this as we differentiate this from psychosis. Contamination and incompleteness, again, kind of being what we tend to see on TV the most. PRO, you might have heard this term before, described as OCD without any compulsions at all. You could diagnose this in the DSM. So remember the DSM, you could diagnose OCD with only obsessions, only compulsions, or both. But PRO is extremely rare, if non-existent. Mental compulsions are nearly always present. So mental compulsion would be something like counting in one's head, mentally reviewing a scenario, or thinking of mantras or prayers. I like discussing this study from 1978. It actually contained 3 experiments. And the question is, do we all have unwanted or intrusive thoughts? So this involved 127 healthy controls, including undergraduates, graduate students, and some professionals. And they were asked about their intrusive thoughts or impulses and the frequency with which they had them. And Rockman and De Silva found that the frequency of intrusive thoughts was similar between individuals with OCD and those without, but the content of the thoughts differed, with OCD patients reporting more disturbing, unacceptable, and ego-dystonic thoughts, so thoughts that seem to go against their values. The key distinction was how individuals with OCD appraised or thought about or responded to their intrusive thoughts, engaging in compulsions to reduce stress. In the healthy control group, intrusive thoughts often involve worries like harming a pet or the health of a loved one. In the psychiatric group, they compared this to conditions were more disturbing, like an impulses to commit violent acts or sexual assaults. And the content of intrusive thoughts could still vary widely between the groups, with the latter being more disturbing or taboo. But when you look at the thoughts themselves, sometimes it's really difficult to tell who was in what group. So disgusting sexual acts with males, remember this was in the 70s, from a male participant, this was in the psychiatric group. An impulse to violently attack and kill a dog was reported from someone in the healthy control group. A thought about whether any harm had come to his wife was in the healthy control. Thought of harm befalling her children, especially accidents, psychiatric. Impulse to utter swear words, psychiatric. Thought that something is wrong with her health, healthy control. Thought that he has got or will get cancer, psychiatric. Thought, did I commit this crime when hearing or reading reports of crime, psychiatric. Impulse to sexually assault a female, known or unknown reason, healthy control. So really, when you look at these, you almost, like when I show these to my students, I'll often cover up the stars and I'll ask them to guess which was which. And there's an even longer list because the article has the exact items they asked. Even it's about 50-50 when I really can't guess what group was what. So the differences in intrusive thoughts then between the general population and individuals with OCD. Individuals with clinical OCD report more bizarre and aggressive intrusive thoughts compared to those without the disorder. The intrusive thoughts experienced by those with OCD tend to be more severe in content, causing heightened distress and impairment. And individuals with clinical OCD struggle to control and dismiss the thoughts compared to those without the disorder. In OCD, these individuals experience them as more spontaneous, arising without explicit triggers. For individuals without OCD, the intrusive thoughts tend to be more reactionary, triggered by external stimuli or life events. Clinical individuals are more likely to appraise their thoughts in terms of responsibility and control, linked to increased distress and frequency of the thoughts. And because of this sign of personal responsibility and need to control them, it actually ends up leading to more distress. While obsessions tend to prompt avoidance, only around 40% of people with unwanted thoughts use avoidance to cope in the healthy control group. So most of them just get these thoughts, they bounce away. And some work suggests that 2/3 of unwanted thoughts in non-clinical samples are focused on the present moment as opposed to the future moment. Unwanted and intrusive thoughts differ from OCD thoughts and triggers, appraisals, and behavioral responses. In OCD samples, unwanted thoughts tend not to be linked to a specific context. They're a little more frequent. The severity of the thoughts for individuals with OCD tend to be related to negative appraisals and more this feeling of greater responsibility. And more severe intrusive thoughts tend to lead to more avoidance behaviors, which could increase the likelihood of experiencing the thought. So this brings us to OCD and psychosis, because if we're thinking that most everyone experiences unwanted and intrusive thoughts, then we're starting to wonder, well, are these thoughts really just lying on some kind of continuum, as opposed to us being able to neatly put them in different buckets? So consider a very brief case example. This is someone I treated many years ago, a 19-year-old male, no prior diagnoses. He arrived in our outpatient clinic due to thoughts that whenever he would shake someone's hand or touch objects that he had previously come in contact with someone else, that he would inherit their personality characteristics. So for example, if he touched my computer mouse, he'd believe that he'd inherit some or all of my personality characteristics. He'd then try to throw his arm outward to try to push the thoughts away. So he'd sit in the waiting room going like this, trying to push the thoughts away. As the thoughts strengthened, especially without treatment, he began to hit himself in the head to knock them loose. At times, he would hit himself in the eye. He started to cause blurred vision and damage to his cornea. He was convinced these thoughts were true. He also articulated that they really bothered him. And there was honestly quite a debate among the clinicians about whether these were delusions, about whether they were obsessions, and it took us a while to figure this out. With that context, let's talk about some of the symptom overlap here. OCD and schizophrenia is a 12 to 14% prevalence rate in some studies. Subclinical obsessive compulsive symptoms can be up to 30% in schizophrenia patients, with even higher rates. So some studies show up to 64% of obsessive compulsive symptoms in schizophrenia, and this is just schizophrenia. So, the obsessive compulsive symptoms, even in first episode psychosis, might be even higher because the threshold diagnosis for meeting schizophrenia is quite high. DSM-5 insight specifiers, so we have the good and fair insight. So we recognize obsessions as unreasonable or excessive, poor insight where we believe obsessions are probably true, and then absent insight or delusional, so completely convinced the obsessions are true. Now, prior to DSM, delusional insight wasn't really a thing. So the case study that I showed you had previously been diagnosed with delusional disorder on the schizophrenia spectrum. For DSM-5, there's now this diagnostic fork in the road with the OCD insight specifier. And in fact, DSM-5 requires thought insertion or delusional preoccupations, as in schizophrenia spectrum or other psychotic disorders, to be rule-outs for OCD. So typical characteristics of insight in OCD, it tends to be preserved. So most OCD patients recognize the irrationality of their thoughts. Poor insights positively correlated with greater OCD symptom severity and poorer ability to resist or control their symptoms. It's associated with fewer mental neutralizing behaviors. And of course, this has treatment implications. So poor insight could lead to worsening of symptoms because there's just less resistance present. And it's associated with less effort in cognitive behavioral therapy, which tends to be the primary mode of treatment for OCD, especially it has with exposure, I should clarify. And so, complex relationships. So how insight relates to OCD is actually rather complex. So for example, Jacob et al. 2014 found it wasn't a mediator between symptom resistance control and OCD. So this is still an active area of research. In OCD, we think about kind of two types of insight where it's state dependent or trait dependent. So this state dependent insight is poor insight is a transient symptom. It's influenced by factors like severe OCD or depression, and it tends to remediate through treatment. Whereas trait-dependent poor insight is more of this persistent feature, which could be linked to underlying schizophrenia spectrum disorders and personality pathology. In any case, we tend to think about insight in OCD considered as a spectrum rather than this kind of categorical specifier as the DSM would like us to think that it is. Now, insight in psychosis involves a metacognitive challenge to objectively assess thoughts, feelings, and behaviors in relation to societal norms and a personal understanding of mental health. And I suspect that a lot of the OCD research probably stole from the psychosis literature. Insight involves an internal process of self-evaluation, and right now we're thinking of two different types of insight. So clinical insight, awareness of having a mental illness and understanding its implications, versus cognitive insight, where we focus on an individual's tendency to question and evaluate their cognitive processes, regardless of the presence of a mental disorder. A couple things to consider about psychosis and insight. The lower the mood, the better the insight, which is kind of interesting, but it's a fairly robust result. And that the explanation here is this kind of depressive realism as mood worsens as insight increases, or the removal of these biases might contribute to a clearer perception of one's difficulties. And we see this a lot at the Bridgeport Reach wellness track, where we specialize in treating individuals with disordered thinking. Metacognitive therapy and training are promising for improving insight and reducing overall symptoms. And then there are a lot of neuroimaging studies where there are brain regions involved in self-appraisal and insight, like the cortical midline network and the default mode network. Obsessions typically involve self-recognition, acknowledged as products of one's own mind, experienced as unwanted and distressing. They cause significant distress and worry, and they're typically met with efforts to suppress. So somebody typically gets an obsession and they typically try to suppress this. They don't want it. Delusions are firm beliefs. They're strongly held despite contradictory evidence. Lack of insight. So they're typically not recognized as irrational. They may not cause any distress or anxiety, and they're generally not resisted or questioned. If we compare the thought content between the two, OCD themes, remember that kind of graph that I showed you with the different subtypes of OCD, contamination, transformation, all of those? Well, if you look at OCD themes, we see contamination, symmetry, forbidden thoughts, doubt. Psychosis themes tend to be more persecution, reference, grandiosity, control. So even the content tends to be a little bit different here. Another example, religious themes can occur in both, but in OCD, patients are often overly concerned with sacrilege, blasphemy, or scrupulosity. So this concern with right or wrong, or with morality, or am I offending God? Am I a good enough Christian? Whereas in schizophrenia or psychosis, patients maybe more commonly have grandiose religious delusions like I'm a divine messenger, for example. Bizarreness of thoughts really can occur through both of them. So psychotic delusions, often highly bizarre and implausible, like my intestines are melting. OCD with poor insight, we can still have bizarre thoughts, but these are less common on average. So for example, there's a case study of a 16-year-old female concerned with turning into Hitler through growing a mustache and male genitalia. Quite bizarre in either case. And then we have cultural considerations. There still seems to be something qualitatively different about these. but I'm not sure that the bizarreness is quite a good delimiter there. So we have to mention ego dystonicity. So in OCD, these are typically ego dystonic, conflicting with one's self-image or their values. In psychosis, they're often ego syntonic, aligned with one's self-perception. But I really want to emphasize here that these are not really well-defined terms. We recently published a paper trying to separate individuals who have bona fide suicidal ideations versus individuals who have suicidal obsessions. So unwanted or intrusive thoughts about hurting themselves or harming themselves without any actual intent to do it. And we looked carefully into this ego dystonicity spectrum, and many people out there will say that in that and in differentiating OCD and psychosis, that we should rely on what's ego dystonic and ego syntonic. And we've not found a whole lot of research to be supporting this idea. The way that we kind of framed this in our writing and our thinking was that if we have thoughts that are ego syntonic and somebody has them and they have OCD, it might be maybe a yellow flag, but it's not necessarily the evidence that we need to identify them as delusions. Resistance to thoughts. So OCD typically involves active resistance against intrusive thoughts through compulsions. In chronic OCD, the resistance could decrease over time. So someone could just say, well, these are part of me. In psychosis, delusions are often integrated into someone's belief system. So they're firmly held, resistant to change, and resisted less. They could seem completely self-evident to someone. And if there is resistance, it could look more like fear or confusion, especially for first onset psychosis, rather than overt compulsive behavior when we think about the behaviors that someone's engaging in. So for example, I worked with a patient who had comorbid OCD and psychosis. For his first episode, he walked up and down the streets just touching light posts. And so these were clear obsessive compulsive behaviors, but he wasn't doing these to alleviate any kind of distress. These behaviors were simply done because he felt like this was a command that he had to do. So understanding the resistance and the why behind the resistance is important here. And this brings us to these behavioral differences in this functional relationship. So compulsions are directly linked to specific obsessions. So unwanted thoughts about harming others will tend to lead someone with OCD to avoiding all sharp objects, hiding all knives, asking for reassurance, like, do you really think that I'm going to kill you? Do you really think I'm going to hurt you? Do you think you're safe around me? These behaviors temporarily reduce anxiety from those obsessions versus behaviors resulting from delusions, which could lack a clear rationale or connection to thoughts, like that patient who is going around just touching a light posts. They may not be done to decrease anxiety, but rather to manage a perceived real-world threat. So someone with the delusion of persecution might engage in elaborate and unwanted or unwarranted protective measures. So they might, secure all their windows. They might put boards up all on their windows. They might engage in all of these behaviors. Their anxiety might not necessarily come down. For them, it's just this philosophical necessity. Like it just must be done. And this is quite different than someone with OCD who would experience that temporary relief of anxiety and distress. We actually talked a little bit about metacognition, even if we didn't call it that. So metacognition is this transdiagnostic factor that's relevant to both OCD and psychosis, and it relates a lot to insight. It correlates with intensity of symptoms, and improving it can benefit both conditions. So OCD and delusions share metacognitive profiles, so a heightened need to control thoughts, difficulty evaluating the accuracy and rationality of thoughts, and problems with mental reflexivity. So it involves like the ability to reflect on mental experiences. So someone who's unable to kind of reflect on their own cognitions is going to have difficulty with insight. They're going to have difficulty taking recommendations from providers. And then neurobiological factors. I don't want to spend too much time on this slide, but there are some neural pathways and neurotransmitter system overlap common to both, like the dopaminergic and serotonergic systems. And then there are some distinct patterns, so abnormalities in OCD increased functional activity in the orbitofrontal cortex, dorsolateral prefrontal cortex, and other areas, abnormalities in schizophrenia, reduced frontocingulate and frontoparietal connectivity, just as examples. These examples then lead us to actually the schizo-obsessive subtype. So these overlapping features has led to this proposal of a schizo-obsessive subtype, where patients exhibit both OCD and schizophrenia or schizophrenia spectrum-like symptoms. And this subtype reflects this sort of continuum between neurosis or OCD and more psychosis, like schizophrenia, which kind of challenges some of these traditional diagnostic boundaries and hopefully makes it a little more sense why I spent 10 slides talking about the difference between some of these obsessive thoughts in the general population and individuals with OCD. Because more and more we're kind of thinking about this as lying on a kind of continuum. Which brings us to this kind of dimensional approach. So viewing symptoms on a spectrum rather than part of an oversimplified diagnostic category. Thinking about symptoms across domains within biological, psychological, and social contexts. And then thinking about diverse symptom presentations. So not everyone fits the mold. It's very possible that we could have someone who is experiencing some kind of psychosis, which isn't quite a delusional disorder and isn't quite an obsessive compulsive disorder. And that is what's going to happen when we play with fire with the DSM and we try to neatly categorize things according to these arbitrary diagnostic boundaries. So just a brief slide on clinical assessment strategies. We need a comprehensive history then, so a detailed exploration of symptom development. So for example, if we have somebody who's in their 20s and symptoms started to begin regarding some of these thoughts when they were 6 years old, this might be a little bit more evidence for an OCD story because of some of those prevalence rates that I showed you. Though again, we have to be careful when it comes to comorbidities. Standardized scales could be useful here. Collateral information and longitudinal observation can also be helpful when we monitor symptoms over time. And this happens a lot for me, especially in the IOP world, when sometimes people come in, we do an intake, and we truly don't know what's going on at first. We really do just have to monitor symptoms over time. And we have to remember that even in the framework of the DSM, diagnoses can be provisional and they can be subject to change. So just a quick summary of some of these separating features. So onset and course of symptoms that we can get through a thorough assessment. Insight, so just overall degree of belief in thoughts. Bizarreness, so the strangeness of thought content. So we talked about how bizarreness isn't the best delimiter, but bizarre thoughts tend to be a little less common in OCD. That ego-dystonic, ego-syntonic kind of spectrum, whereas in OCD, thoughts tend to be a little more ego-dystonic. In psychosis, they tend to be a little more ego-syntonic. Efforts to suppress thoughts. This happens far more in OCD as opposed to psychosis. Hallucinations and disorganized speech, obviously going to be present in some of the psychotic disorders, but not necessarily present in OCD. And then the necessity for just follow-up assessment and further evaluation of the course of the symptoms, because sometimes we just need more information. Sometimes we just have to accept that the 90-minute intake that we do is insufficient, and we just need to collect more information over time. And the other thing that's on here, but not explicitly stated, is understanding that functional relationship between thoughts and behaviors. So trying to understand what someone does when they have some of these thoughts. So if they have some delusions of grandeur, or if they have certain kinds of unwanted or intrusive thoughts, we might ask, well, what do you do next? And trying to think about which one of these frameworks might best fit here. So just a quick slide on treatment approaches that's overly simplistic. So this is from the American Psychiatric Association's guideline here on the top for treating obsessive compulsive disorder. So for OCD, really primary treatment, CBT with exposure. With inadequate response, we move to secondary treatments, which are SSRIs as either conjunction with CBT, or sometimes we could do SSRI monotherapy. For psychosis, others here with more experience can chime in, typically antipsychotics, secondary treatments involving psychosocial interventions like CBT for psychosis. In our comorbid presentations, we want to do a combined presentation, or I'm sorry, a combined treatment approach, and then think about a tailored approach after that. So for example, a young man I saw for many years who was diagnosed with schizoaffective disorder and OCD, for many years, it was just a lot of medication management and trying to get him to remain on his medications. And when he was finally at that stage, we were able to treat some of the OCD and some of the lingering social anxiety as well, as his quality of life began to improve. Future research directions, so more targeted treatments, so developing interventions for specific symptom profiles, longitudinal studies like tracking symptom evolution over time, and really starting to think dimensionally. Some honorable mentions I included on the bottom, like improving reliability and validity of diagnostic categories and identifying biomarkers. So I want to run very quickly through a model of OCD with you all. I won't spend very much time on this, but I do want to contrast the description of the DSM's description of OCD, which is just obsessions, compulsions, or both occurring within a certain time frame, with a true model of OCD. To give you an idea of really how we're thinking about OCD and what I think is needed. OCD, we need to understand complexity, consider nuance, and really embrace subjectivity. And we need to move away from this checklist because the DSM has many limitations because it is purely descriptive. Whereas OCD is complex with diverse manifestations, many of them include psychosis. And you'll notice that there really is no mention in the DSM about OCD and psychosis. And we need to move toward a model where we understand mechanisms, identify factors that pinpoint cognitive, emotional, and behavioral factors, that discuss maintenance of OCD symptoms, and that really help us guide treatment approaches. So this is sort of the classic and simplistic OCD cycle, where we have unwanted or intrusive thoughts here on the top that lead to anxiety. The anxiety leads to compulsions, and the compulsions are done to give us relief. When we get that relief, it tends to strengthen obsessions. So this is the model that I would more or less show my patients. We can revise this model by adding an additional piece where we have intrusive cognitions would be our obsessions, and these are interpreted maladaptively. So for those of you who understand cognitive behavioral therapy, we have unwanted or intrusive thoughts that are interpreted maladaptively. So somebody might get this unwanted or intrusive thought of, harming somebody, and then they might think, oh, I'm a bad person for having this thought, which then puts them back in this cycle of anxiety, doing compulsions, getting relief, and it strengthens their maladaptive interpretation. We can then add context and interoceptive stimuli, so the stimuli we feel in our bodies, just like fear, to the intrusive thoughts, and then attempts to control. Remember, individuals with OCD, they want to control. We could talk about avoidance. So we have sensory or contextual stimuli coming in, but we avoid. And so this block here prevents us from actually experiencing the world. And when we avoid, it strengthens this maladaptive interpretation. Cognitive distortions. So again, those of you who've spent any time with cognitive behavioral therapy, overimportance of thoughts, overestimating threat, inflated responsibility, all of these can influence our maladaptive interpretation. And then it's not just about anxiety. So here in this box, we add incompleteness, we add disgust, because sometimes we can get thoughts in our head that don't just elicit anxiousness, but maybe they just make us feel disgusted with ourselves. And this disgust can feed back into the way that we interpret our thoughts. We add operant conditioning. So anxiety, incompleteness, disgust lead to compulsions, which lead to relief. And then this is negatively reinforcing our compulsions. So all that stuff that we tend to learn in intro psych comes back to haunt us here, where we add negative reinforcement. We can add habits here on the side, which are these shortcuts. So instead of having to go through this whole roller coaster here, a habit is, oh, we see something, it immediately triggers us, and then we do a compulsion. We don't even have to have the thought. It's just, bam, compulsion. And then lastly, we kind of put it all together. Now, admittedly, this is far more complicated than what's in the DSM, but we can ask ourselves as clinicians, where would we intervene here? Where does, for example, exposure and response prevention work? Where, for example, does the insight that we talked about earlier matter in something like this? Where does psychosis serve as a barrier in a model like this? This lets us think about that more than the simple description of the DSM. And so when we revisit our case study, the primary thoughts are the concern that the patient would inherit others' personality traits. These are clearly bizarre. The behavior is done after experiencing the thought where throwing his arms outward after pushing the thoughts away. And so it did show that he was engaging in some resistance. There were no other symptoms of psychosis, so no other hallucinations, no disorganized speech. Reality testing, so he was able to do this. So there was some indication of the patient's ability after considerable effort. You really had to dig, but he was able to say, this is a little odd, but you really had to dig. He did find the thoughts to be highly distressing and he didn't want them. And so ultimately, we diagnosed with OCD with delusional insight, and we were able to treat successfully with exposure therapy. So that's all I have for now.